There we go. All right. Hi everyone, I'm Mark Corden. I'm a paediatric emergency specialist in Melbourne. This is the one token paediatric talk of the conference. And it's not going to be sexy, it's not going to be cracking people's chests, it's not going to be ridiculously graphic X-fix. It's going to be the stuff that is slightly boring, but is why people will bring their kids to you. Okay, so just who the hell am I? So I'm a paediatric emergency specialist. I work at the Northern Hospital, which is an outer metro hospital in Victoria. It's the second busiest ED in the country. We usually tie with Fiona Stanley in Perth, and Gold Coast is number one. We're the busiest ED in Victoria. We see a ton of kids, hugely broad sort of socioeconomic. We have people from 185 countries, speaking 109 languages, 90 different religions. I'm a father of 3, which is why I look like this now. I do some silly quizzes for Life in the Fast Lane, and I've been lucky enough to speak here about 4 times now. I also make a ton of balloon animals at work because kids don't like you. So if you can bribe them, there's nothing unethical about that in my opinion. And when the balloon dog appears in the talk today, now the talk I've written for this conference, so I might have stuffed up the timing and don't even know that yet. But when the balloon dog appears, there will be a very paediatric point to be made. All right, so, but why this? So what's the topic talk? The topic is not hard to do well, but easy to do badly. Basically, that's going to be around sort of communicating with children, communicating with families, and I'm going to tie in the really common pathologies that we see, that you will see, because you're the medico in the family and friend group, so you probably get all of these, little Timmy's sick, little Susie's vomiting, what do I do? And it's how to answer these questions really calmly and really well, hopefully. Parents that come to the ED, parents that call an ambulance, parents that are asking for help, they are frequently overwhelmed. The kid has probably been up 2 or 3 nights, vomiting, coughing, feverish, doesn't matter. So the parents have been up for 3 nights in a row. The older people in the crowd, we know this, the young people in the crowd, it's kind of like a cerebral argument, but you haven't experienced that level of tiredness. And now you all think, I'm a shift worker, I know what tired is. You've got no idea. All right? So parents are overwhelmed, and their ability to mentate in that frame is absolutely reduced. And that's not judgmental, it's absolutely evidence-based. So it's how do we regain trust in a patient and a caregiver who is somewhat compromised. Okay. This is a question that I think is going, are you worried your child is getting worse? Can we measure the impact the parent has on their child and in their illness? That's really hard. But what we can measure is the parent's appreciation of their child. This was a study in 2025 Lancet, and the question was, are you worried your child is getting worse? If the parent answered yes to that question, they were nearly 4 times more likely to end up in the ICU, 5 times more likely to actually die in the event of in this hospital impression, and more likely 5 times to be mechanically ventilated. So the parents do know what's going on. They might not know why the child is sick, how the child is sick, not quite sure what's wrong. That's not their job, that's our job. But they do know their child inside and out. So my approach to this is when I'm trying to get on a good, even playing field with the family, my line is, look, I might be the expert in this, but you're the expert in your child, thus we need to be together on this. And they are, because you need to empower them. We can sort of say, oh, there's a flat hierarchy, there's informed consent. You are in a position of power because you are a healthcare provider. They are not in a position of power because they are seeking your help. But there are ways to try and level the playing field whilst not dissolving the sort of power differential that exists between healthcare provider and healthcare seeker. All right. Quickly, I do like to give out prizes. My mother frequently tells me that I'm never going to make friends with my looks or personality, so I'm not above bribery. If I could borrow one of Peter's children to hand out stuff. There's 2 bottles and 2 kids. Thankfully that worked out. Alrighty. So this question, just to, hopefully if this is the only thing you remember, at least it's a fun thing. My favourite, are there any registrars in the audience? I'm not going to pick on you, just hands up. Great. You know how consultants have these obnoxious, esoteric questions you've got no chance of answering and they love them to death? Yeah, this is that. Alrighty. 250 people in this audience at least, collectively about 1,000 to 2,000 years worth of prescribing and dispensing PRN medications. What does PRN actually stand for? Oh, who said pro re nata? Well, what does that mean? No bonus points for this one, but what does it mean? Not correct. He still gets the bottle. Well done. The literal translation is for as a thing is born. So as is required, as is contextual. But yes, years and years and years of writing PRN and we've had no idea what it meant. Okay. So what are we going to do? We're going to talk about common problems, expectations management, which is a bit of a financial that we want at the end. Okay, have a seat, rest your legs. Which is a term that a friend of mine in insurance used, but I thought is an excellent term and we should use it much more in medicine. And then some basic communication. Now, and all know we know how to communicate, we're better at communicating, but there are still some tricks with children, with teenagers, with young people. Through all of this, I'm going to do the whole classic TED Talk 3. If you take away nothing else but 3 points from this talk, it's going to be that good communication is essential. Now, I mean essential. If the parents don't like you, they will not follow your advice. I had an old school paediatric boss of mine a long time ago. He said, it's their business. They can do what they want. But if they don't like you, they don't follow your advice, you've wasted an hour of your time or however much time you have with the patient, and you've wasted their time. And if you genuinely know and think what you're doing is the right thing to do for this child, then it is your job to communicate it in a way that's really palatable. You bring the patient with you. Jargon is death to that. The second we start using jargon, oh, these antibiotics are prophylactic, oh, just give it PRN, you've absolutely stuffed it. It might be a comfort thing. You know, it's a comfort language for you. We know the jargon. And it might even be, look, I really know what I'm talking about. That's why I'm really comfortable with this language. But they're not. And it comes across as obnoxious and otherly. And the last thing, one of the commonest things I see my junior doctors doing is what I call premature reassurance. If you go in all guns reassuring straight away without really understanding the parent's concerns, the child's concerns, you will come across off as dismissive every single time. So these are the 3 main points I want to talk about, and we'll talk about them through these 4 main problems. So, like I said, it's not a sexy talk. People go back to Australia, what happened to the emergency conference? Some bloke talked about constipation. It's not a really emergency, but it is a common reason to present to ED. And this is honestly not as graphic as you'd think it'd be. So I want to tell you a story about a little kid called Aiden. Aiden's changed his name. Aiden saw me because he fell off a trampoline. I mean, I don't know, what was it? It was the other one. It was the monkey bars. A little single foosh, buckle fracture, no problems. But Aiden was fairly withdrawn. He was really anxious seeing me. Seemed like a really nice kid. The parents were really nice. But just going through the basic thing of not, you've fallen off, cool, here's an x-ray, here's a splint, go home, thanks very much, mate. But just some basic background. Is there anything else to know about Aiden? Just some basic standard background questions. Mum said, oh yeah, he's got some constipation. And he was really withdrawn. He kind of flinched at that word. I was like, okay, tell me about that, because I'm a paediatric emergency specialist, but there are 2 species of those. There's the ASIM PEM, the emergency person who does a bit more paediatrics. They'll happily do a central line and everything. And then there's a paediatrician, me, who then does a bit more acute work, and then we're also emergency. So this is absolutely my bag, talking to parents about their children with constipation. Aiden had been a fairly normal kid. He'd always struggled a little bit with his bowels, but no real problems. Starts school, foreign toilet. He's in grade 1 now. All through prep, he was struggling a bit more. And in the holidays, he just couldn't do it anymore. He could not poo. Every time he went to the toilet, it was a screaming, pardon the pun, shit fight. He was distressed. He was scared. Parents were frustrated, like, just go to the toilet. They'd seen their GP. He said, get some laxatives from the pharmacy. No worries. Have some pear juice, prune juice. Some sensible advice that you will hear and see commonly for children with constipation, but just not done in the right way that it made an impact. So this is honestly the archetypal example of something that's not hard to do well. We're going to try and talk about my version, at least, of doing it well, but easy to do poorly. You know, go for a walk after a meal, have some pear juice, go to the pharmacy and pick something up. Well, what do you pick up? How long do you take it for? What are you trying to measure here? These aren't hard questions to answer, but they're easy questions not to even ask. The thing with Aiden was this goes on. The more and more constipated you get, the completely insensate these kids become. They get overflow diarrhea. They soil themselves with stool without even noticing. So he was beginning to skip school. His parents were being called in to pick him up. They were losing income from work. Like this, it seems simple, but this actually was very close to destroying the family. Okay, so constipation is ridiculously common. So the first thing to say is, mate, it's not just you. Okay, a lot of kids, up to 30% of kids. Come on, that's like 3 kids in your class will have this problem. That's 3 kids in every class, everywhere, ever. It's not just you, mate. Now, it's not a mathematical diagnosis, X poos in Y days. The diagnosis, if you need to label something, is basically the painful passage of hard stools. The main dog thing I want to talk about is most of it is functional. It is behavioural, but I want to take that term and completely say it is not a judgmental way of saying it. If you say, oh, it's a functional thing, it's the kid's fault. Kid's problem, come on. Imagine how this happened. You've got a kiddo, most of the constipation happens around times of stress. Parental separation, toilet training is massive, starting kinder, starting school, all these sorts of things. Kids been pooing fairly normally. They have one poo, it's larger than normal, that was unpleasant. Kids aren't stupid. If that hurt, I don't want to do it again. So the next time they come to poo, they hold it in, and yeah, I probably look quite constipated right now if you get up the front. Sorry, Peter, he sees me being constipated. And then they hold it in for a bit longer, and then the next one is even bigger and even more painful, and that's it, done. You've now got a constipated child who hates every single bit of it, and the family slowly descends into turmoil. Okay. So how do we undo this? Firstly, it ain't your fault, buddy. This is common, and he's not doing it on purpose. He hates it as much as you do. Do keep it simple. So there's all the simple advice, and people get drowned in simple advice. So just label the simple advice as simple, and then move on. Okay, so yes, diet and fluids, but people will put prune juice and pear juice at the front of everything they do, and then forget everything else. A bit of exercise. We've seen patients who are bedbound who are completely blocked up. So a bit of a walk, a bit of a play, a bit of a jump around and a dance after meal times to keep things moving. More frequent bathroom visits now, like 10 minutes twice a day. Treat it like physiotherapy. You know, a bit of physio on the bowels twice a day. Sit on the toilet, watch an episode of Bluey. Or keep the bathroom fear hopefully as low as possible. So you can watch my phone, mate. You can have a book, have some music, have a toy in there, and the little squatty potty. So bring the knees up to help as well, because people do poo better in a squat. And that is actually the Squatty Potty brand. Why do parents get set up to fail? Because they say, go to a pharmacy and just get some stuff for the kids' bowels. Well, there are about 9 products, 10 products that you can just go in and purchase over the counter. What's the basic rule? If there are 10 medicines for one condition, it means not one of them is actually any very bloody good, because if there was one that was very good, there'd be one. So they get all this advice, and it's confusing and horrible. So how do you make the not so simple a bit more simple? This is just a copy and paste of the clinical practice guidelines from the Royal Children's in Victoria, and then I've literally just copied and pasted it, cut out all the silly words, and I give them this. And the main thing here is this Osmolax or Movicol, which is Movicol, it's macrogol, it's a bit of a pusher, a bit of an osmotic agent. And this is where you can get the expectations management. Why do they fail medication? You give them a couple of doses and nothing happened. Of course nothing bloody happened. What you have to do is you start on day 1, say they're a little kid, say 5 or 6, you give them 2 scoops or 2 sachets, and then on the next day you give them 3, and the next day you give them 3 or 4, the next day 4 or 5, until you actually get things going again. And then, do they stop straight away? Absolutely not. You'll come bounce back to where you were. You have to set the expectations. I'm going to ruin everyone's nighttime routine. So you get the poo a bit softer than normal so that bowel physiotherapy can rehab itself. So you want the poo softer, roughly the consistency of toothpaste. So I'm sorry about that. And then once you've got that, keep that for a week to 2 weeks, and then go back down. Don't just stop. Go back down until they really only need 1 or 2 sachets every 1 or 2 days. But this is an example of how it's not hard to do it well. There you go up, then go down, aim for the toothpaste, sorry. But every other bit of advice, when it's not just a bit consistent, sets the family up and they're going to be stuffed. So Aiden had been doing this for over a year. He was skipping school, parents were losing work. They had seen doctors. The doctors referred them to a paediatrician, but that wasn't for another 12 months. But just as a paediatrician, I could see this kid sort the arm and actually just go, right, this is not that hard. You can get it done, mate. All right. Now, I don't need questions at the end. If anyone wants to interrupt and ask a question now.
So your recommendation in this scenario is consistency. Don't just do it once and hope for the best. Keep going every day and increasing the dose until things get better, and then decreasing the dose to
Yep.
keep things going better.
So the question was, is my recommendation just being consistent? Absolutely. It's like set the expectations, then give them a plan to follow and a plan to follow out. Yes?
Any tips on the Osmolax? I've come across a lot of kids that just will not take that. Any tips on how to make that more palatable?
So the question is, what about Osmolax? Osmolax is Movicol, but without the balanced salt. So my experience is actually generally fairly opposite. It's the drug without the salt, so the kids can't get the flavour. You can chuck it in the bolognese, you can chuck it in the milk, the pear juice, the prune juice, water, anything. So hide it is the short of it. Put it in the ice cream if you have to. But if that doesn't work, there are other agents as well. If they've just decided that's the worst thing in the world, try something else, but keep the plan the same. Use as much as you can consistently. Don't just give it 2 days worth and then hope for the best.
What's the easiest one to hide?
My opinion is Osmolax is actually very easy to hide.
Okay.
But you can put it in food, milk, juice, anything.
Thank you.
Yeah. You didn't pay, so you don't count. Oh. In a nice way. All right, so pain relief in children. Other stupidly common thing that parents never get consistent advice on, and they just get turned around. And your child's in pain. You want to do it right, but you haven't really been told how giving pain relief in children is done well. Firstly, there's the simple stuff. There's the good first aid that we can't forget about. If it's burned, cool it. If it's broken, splint it, all these sorts of things. You can distract a kid really well. Bluey is the best thing in the world, in my opinion, with a father of 3 small children. And you being calm is incredibly helpful. If you're calm, parents are calm, kids get calm. So that's really, really helpful. The Panadol and the Nurofen, the Tylenol and the Advil, or whatever we want to call it. This is where things get really tricky, because what's the strict advice? Well, the strict advice is easy. Panadol is every 4 hours, no more than 4 times in one day. Nurofen's every 6 hours, no more than 3 times in one day, but always on a full stomach. And then the parents are looking at it with cross-eyed and they've got no idea what you've just said. It's extraordinarily difficult when they haven't slept in 2 days. So how do you actually help them out? Before I get to that, the balloon dog, you must never give Nurofen on an empty stomach. In paediatrics, don't worry about it. Actual NSAID gastritis is real, but generally when the kid has been giving massively super therapeutic doses of Nurofen for days and days on end, and even then it's still very rare. So my impression is give the Nurofen, because most likely with the pain relief you get from it, then they're going to start eating. So if they haven't eaten, they've been vomiting, they've got tonsillitis, they haven't eaten for 2 days, they've barely had their bottles, give the Nurofen. It's absolutely fine. And what's the thing? Do you tell them, yeah, Panadol's every 4 hours, and no more than 4 times in a day, and Nurofen's every 3, but no more than... No, very simple. You keep it simple for the family, not in a condescending way, but just in a simple way. If my kids go to date, this is basic banter. My kids are all school and daycare kids, they're always sick, they're always sore. So if it's my kids that are sick, and they're a little bit sick, I'll give them one or the other, whatever they prefer. In my house, it's Nurofen because it tastes better, so there's less fights. But if they're proper sick, well, then I'll give them both at the same time. And the parents usually ask, do I have to halve the dose? No, they're different chemicals, different medicines. They're both pain relievers, they're both fever relievers, they both work really well. They complement, but they don't overdose in any way. So give the full doses on the bottle. Is it 4 mils, 6 mils? I don't know, you've got a different brand. Just on the bottle, go with what that is. And then with them both together, you've got 6 hours. You can come back and say, okay, mate, do you need one or do you need both? It's as simple as that. Some families will be told to alternate. You know, you give Panadol, then 3 hours later Nurofen, then 3 hours later Panadol, then 3 hours later Nurofen. And if that works for your family, brilliant, do it, no worries. But I haven't slept in 2 days with my sick child and I can't remember what I've done. So I like the together thing. If you like the alternate thing, go for it, no judgment. All right, if you're in the hospital or the ambulance context and you want to use something a bit more strong, endone in paediatrics is not hillbilly heroin. It is amazing. You do not have to worry about overdosing a kid. If you just get up whatever pharmacogram you have, you can dose it very appropriately and it's an excellent drug. We loathe codeine in paediatrics. So I say we, I mean me, but let's all hate codeine together. You hate it? Excellent. Love the hate. In the ambulance though, you guys do love the fentanyl, and as a peds emergency specialist, I do love the fentanyl for children as well. The doses are excellent. The doses are very easily set up on our nomograms. And again, so Panadol, Nurofen, fentanyl, endone, done. If you are excellent at regional anesthesia, you know your ultrasound machine inside and out, you're doing better than me because I go to bed at night listening to my own arteries harden. I don't have as many ultrasound skills as I should have. Pain relief talk was the one I did. All right. The fever. The fever. This is probably 20 to 30% of my job. And it'll be a lot of your job as well. So again, it's not the sexiest thing, but it is the stuff you're going to be seeing. So this isn't a talk on status asthmaticus, on sepsis, on massive trauma, on seizures. Well, actually there is seizures coming up, but fevers. Fevers is 20-30% of paediatric healthcare seeking behaviour. So let's go through it. This is one of the reasons why people sort of hate paediatrics. I think they're lunatics, but you know, the child can't tell you what's wrong with them. In my mind, there is almost always a clue. You know, frequently the clue is, oh yeah, they started daycare 2 weeks ago. That's a big clue. Sometimes it's really simple, like, yeah, they're still taking most of their bottles, but they haven't eaten solid food in a day and a half. I'm going to look at their tonsils, 100%. Feel their cervical adenopathy. They might be pulling in an ear, they might have fallen over. The truly, truly undifferentiated child, they've just started screaming for no reason, they're febrile for no reason, is actually rare. Children aren't as scary as we might think. Although that being said, I think adults are horrifying and scary. So I can appreciate why anyone here, if they don't do kids every day, would be scared of kids. But hence this talk. Most of the kids who present with febrile illnesses, well over 95%, if the fever is less than 5 days, the cause will be a benign viral infection. Okay, so even if you get it wrong, yeah, the child's going to be all right. One of my favourite slides. Can I go back? The point before was fever is 38 degrees. You can debate that till the cows come home. My personal opinion is there is no physiological reason to be over 37.4 degrees C. There were a couple of decent, not good actually, studies a while ago on teething children, because everyone always says teething gives you fevers. No. A physiological rise to 37.4 can be from lady things, from diurnal variations, from teething, from other physiological things. Once you get to 37.5, there's generally something else exogenous happening. So my definition of fever and COVID's definition of fever, not that I like to get along with COVID very well, but they were together, is 37.5. Other people will have different opinions, but I'm of that ilk. All right, the pitfalls. The kids who look well are unwell. This is like the well child or the unwell child is a massive talk in itself. I won't bore you with that, but things the parents will ask you about. The fever is so high. Maybe they have a thermometer at home. Some thermometers we like, some we don't. There is actually a bit of evidence that once you get over 41, the rates of meningitis are increasing, but under 40, 37, 38, 39 to 40, there is no real linear correlation between that number and how sick the kid is. The parents will not agree with you on that. The fever came on really quickly, independently asked, and does not matter for veracity of infection. Didn't go away with Panadol. Just means the Panadol didn't work this time. But getting their parents, these are the questions you get asked. And then they had a seizure. What's the difference? The babies. If you have any fever in a neonate by definition is the baby in the first 4 weeks, 28 days of life, we hate that. The one caveat now is this the pointer? Oh, yeah. How the temperature is taken actually matters, because 10 years ago we had axillary and tympanic. Babies' ears are way too tiny for them to tympanic, so piss that off, pardon my language, remove that. And so we just do axillary or rectal. But now everyone buys the most expensive one, the forehead zappy one, which most paediatricians think is little better than a random number generator. There was one good study out of Turkey that actually went through 150 kids, measured all their temperatures, all the different ways, tympanic, axillary, rectal, and forehead zappy. And they found that for old people like us, well, me and everyone above, it underestimates your temperature by about 0.6 of a degree. For neonates, it will overestimate your temperature by 0.6 of a degree. So you might have a kid who's 37.6, which is technically normal for a neonate. The forehead says 38.2. So are we going to give that kid blood tests, antibiotics, a lumbar puncture, and a needle into the bladder to get a sterile bladder sample? Well, it's hard to answer that question. So then you get to go back and say, okay, well, why did you take the temperature? And that's a better question to ask. It might be a really good answer. They feed beautifully every 3 hours and they haven't fed for 8, and they're really irritable and flat. Okay, that's a good reason to take a temperature. I'm probably going to be more likely to do all the bloods and things that I want to. Or I just do it twice a day because I'm super stressed. Okay, cool, less worried. So there's still context. You still get to use your brain and do all these things. Why do we care so much about babies? They're nice, yes, but a fever can be in the first month, the only sign of an IBI, an invasive bacterial infection. Thankfully, 6 weeks ago, no, go back. Shit. Quentin. Thank you. Too much? No, they went forward. 6 weeks ago, there was so really up-to-date evidence. There was an article that was published, IBIs, invasive bacterials, and of those, 0.7 doctors, I'm really sorry. The one thing you guys will do stuff up is that we go, oh guys, febrile convulsions, we know they have really great outcomes. They're going to be fine, don't worry about it. We walk away. But 90% of parents, when asked, thought their child was physically dying in front of them, which is an emotion I can't even begin to contemplate. So the worst thing to do is, oh, they're going to be fine, don't worry about it. The way I do it is, I tell them these numbers. I'm like, from a really good study of 140 families, we do know that parents who've been in the position that you're in, when asked, because they sit there like, why is no one stressed? When asked, think that their child was about to die. They go, yes, that was me. Okay, absolutely. Because that's just what you've gone through. How the hell then can I tell you your child's going to be okay? And then you can unload the basic knowledge on febrile convulsions on them. All right. Okay, expectations management. The best example of expectations management is, so fevers at 20-30% of a PTD workload, welcome to 10%, tummy pain. Tummy pain in children is exquisitely common. It's 10% of my life. And how do you do expectations management in this? What we know about abdo pain in kids is if you get 100 kids and do all the tests you can think of, every urine test, blood test, ultrasound scan, CAT scan, Simon's MRIs, you'll have an answer. Your child has X half the time, which means half the time you can do every test and there's no clear cause for the child's pain. And I tell that to the families because I want to lower their expectations of me, because half the time I'm not going to tell them what's wrong. But what I do tell them is, and this is how I teach my registrars, is this is the one context when I want to walk in arse backwards, because I don't want to know what's going on. Half the time I never will. I want to know what's not going on. So I have this list in my head. I work through it. If nothing's on it, kid will probably be okay. If you like lists, you can go through the style, sudden onset, colicky sort of thing. And if anyone wants these slides, just come up and say good day and I'll email them to you. There's no problems. If you really like there's that, which gives me a migraine, but the children aren't often very well. Things that are super common, parents worry about appendicitis, which is fair. Children actually usually do read the book. After the age of 4, and most appendicitis happens after the age of 10, they'll have the classic central pain that moves down. Pediatric specific things, can you jump? If they can jump and fall down, that's an appendix. And you ask them, on the way in, could you tell the bumps in the car? And if they say yes to that, it's a ridiculously sensitive sign. And it won the Ig Nobel Prize. Okay, the last thing I need 5 minutes for is talking to teenagers. Now, talking to teenagers is hard at the best of times because they hate themselves, they hate you, they hate everything. I was a teenager as well. We all were. So how do you actually do it? Don't stuff around with a teenager, just be straight. They need nothing but your honesty. They're hard to take care of, so at least be honest about it. Self-deprecation works. You know, I'll say, look, mate, I'm 46. I can't. If you run out of here, I'm not going to run after you. I fall asleep at night listening to my own arteries harden. So, and then how do you talk to the adolescent alone? It is their right to talk to you in a patient, doctor, confidential way. How do we do it? How do we do it? The worst way is the way we often do it. We walk in, we start normally. Oh, hey, I'm Mark, I'm one of the doctors here. I see you got some pain in the tummy, so let's just see what's going on. And then you get to the end of it, you want to ask some questions like, now actually, I actually need you, parent, to leave so I can talk to you alone now. Super me v you, super judgmental. Remove all that. Start with expectations management. Walk in, say, hey, I'm Mark, I'm one of the doctors. You're a teenager with some tummy pain, or you're a teenager with something. So we're going to do it the standard way, what we do with teenagers. I'm going to talk to you all as a family unit about why we're here. Then we are going to get the we language, not I-you language. We're going to get the parent to leave. Then I'm going to ask you all the awkward teenager questions. Then we're going to get the parent back in, and then we're going to do it all. So you set the expectation. So when you meet the expectation, it's not awkward, and you actually get to do it. All right. If you really want to, you can do a head screen. That's the basic acronym for all the questions to ask teenagers. And you can use some teenagey language. If you use it badly, they will think you're an idiot. So they are now superior to you in all of their world, and you are only superior to them in your world, which is the medicine world. Now it's more equal. Now they look down on you. Now they'll actually interact with you a bit more. So feel free to use teenage language, knowing fully that you're going to get it wrong. Like, I'm vibing that you're not really good here, like, good God. You know, hey, no cap, is that true? Like, you know, it's all these sorts of things. So, you know, I'm trying to slay it up here. I'm trying to give main character energy, and they're drowning, they're turning white. Use it, they're going to laugh at you, they're going to hate you, and then they'll talk to you. I'll be honest, like, hey, I'm older than Google, and that blows their minds. And I'm not on the Instagram, Snapchat thing, so I don't know what it's like to be you, but help me understand. All right. Okay. The last two things. Kids, this is what we look like to them. All right? So get down low. Get down low, get on the ground, get on your knees. My knees are shit. I still get on the ground. You don't have to stop, drop, and roll, but you do have to get down low. All right. I'm going to go to the end. I'm like basically to the end. All right. Can we do evidence-based medicine? Yes. The second you sit down on a chair, on a stool, parents will like you more. And if they like you more, they're going to follow through with your advice more. So there are better health outcomes by just getting down low. So I really stuffed up. Like I said, timing, nothing else. The jargon. If you use jargon, it is immediately taken as, I know more than you, you can't possibly understand, you're not going to understand these words, just do what I say. And when you say do what I say to someone, their answer is again, a big old F you. All right, so try and avoid jargon. Don't simplify everything. If you have to use jargon, just explain it. If I say, hey, if we're lucky with your child's abdominal pain, we can just use conservative management, which is, of course, a fancy way of saying doing nothing, getting away with it. They like that. So you can use jargon if you explain what it is and why you're using it. Because it basically creates a fence. You're here, they're there, you're not on the same team. and you will not win unless you're on the same team. The reassurance we spoke about, so we're just going to get to the second bottle of yuzu. Are you ready? For this? All right. So my traditional question is, what is the point of the sinus of Valsalva? How does the aortic valve close? It's actually a brilliant question. I'm going to answer very quickly. It is not the retrograde flow from the now negative pressure when the ventricle stops pumping. It is the Valsalva that actually causes eddies. It pushes the valve in from the side. Who was the first person to discover this? It was Da Vinci, 500-600 years ago. That's my second favourite obnoxious question of all time. But because of the talk today, we're going to say, what is the meaning of "you ate that"? Who can answer that question? What does "you ate that" mean? You did really well. Yeah, you ate that. Yeah, you did good. I was going to say slayed.
And left no crumbs.
Ate that and left no crumbs. Bugging me. All right, so up the back there, that was a good one. The other one was giving body tea, but given Matt did some jacked teenager yesterday, I thought I won't do giving body tea. Google it. We'll do "you ate that." So please, any questions? I know I've gone over. I did the timing wrong. If there's any questions at the end, please come find me. If you want the talk, email me. But thank you very much.